preparing live stream. See what happens.
Is Christy able to see it if it is?
Yeah, she probably is.
A little banner just popped up on mine. It says live on Facebook.
Awesome. Hey, Eric.
Hey, Brad.
Welcome to DocTalk Live. So we are supposedly streaming live. Fingers crossed. I'm still technically challenged, and I'm glad you are too, Eric. So
yeah,
that makes two of us.
Yep.
So I'm with Dr. Eric Driver. Eric is a periodontist. Is that right?
Periodontist, that's correct.
And you're out in California?
Palm Desert, California. It's near Palm Springs.
Awesome. And we're going to talk today about dental implants.
That's correct.
Is that like getting a new tooth?
It is. So a dental implant is a tooth replacement option. It's one of several options that are out there that exist. But it's actually, in most cases, a patient's best option to replace a missing tooth.
So I was doing a little digging today because a Facebook friend of mine who I haven't spoken to in years and years and years posted something a few months ago about dental implants, and it was quite an interesting post, and I'm going to sort of paraphrase a little bit, but the gist of it is that more and more endodontists, as opposed to periodontists, are opting not to do a root canal, but to do a dental implant, and they're really not well trained to do that. That it's not really part of their training, but because of the money, they're incentivized to perhaps do something a little bit out of their area, and that is maybe not in the patient's best interest. And I open with that because I want to capture the audience in terms of perhaps the issue and to create just sort of that scenario. Do you think that's true at all? And if so, could you talk a little bit about what a periodontist is in that regard?
Right. So maybe the best way to answer that question is to kind of define my field in periodontics. And periodontics, really, our field focuses on gum disease, and it ties in with that. You have bone grafting, tissue grafting, tooth extraction. That's a big part of what we do, complex extractions. We dive into a little bit of pathology with biopsies, and then the replacement option with dental implants. And the implant portion of our residency and our training is significant. I mean, we do a deep dive into all the literature and really get into the weeds with the history, the biophysiology of the implants. And so the knowledge base is there for us to effectively look at a case, treatment plan it, and then execute it in a way that we minimize any potential complications and minimize the risk for any problems long term.
When is it time for a root canal, and when is it time for a dental implant? And how should patients sort of sort that out? And
so I think if you've got a situation where you have a tooth that has relatively few problems, the periodontium, which is the bone and the gum tissue around the tooth. If the bone and the gum tissue are healthy, and you just, bad luck, you have a tooth that dies and it needs a root canal or an extraction. So, and if the patient is younger and you have a reasonable chance of success with a root canal treatment, then I always tell a patient, have the root canal done, because you're young, everything else around this tooth looks good. And then you always have the option for a dental implant down the road, because the dental implant is really kind of your terminal option. I mean, that's it. After the implant, that you don't have any other options. I mean, if the implant were to fail, we can always redo it. But I tend to, lean towards if the tooth or everything around it, you have an overall pretty healthy tooth, do the root canal.
So once you have a dental implant, it's harder to redo it. Is that what you're saying?
There are challenges, yes, and we'll get into that a little bit. There are some challenges that come up in removing a failed or failing implant and then redoing it. Another indication that maybe would be good to do a root canal is if you have, say, an existing bridge. You have an existing bridge on an older patient. One of the teeth that anchors that bridge needs to have a root canal. That tooth died for whatever reason, cavity or trauma, whatever. The tooth is dead, but you already have an existing prosthetic anchored to it. That's a different scenario because now it becomes far more costly if you need to take apart that bridge to do a dental implant and then do all new crowns to kind of restore the case. That scenario, a root canal is not a bad option because it's the less costly and sometimes, very predictable way to treat the case. Dental implant is fantastic when you're talking about the terminal tooth for the arch, the most distal tooth of a space where you're not able to do a traditional bridge behind it. There's nothing behind it to bridge to. So you have to go with an implant in that scenario because there's simply nothing else to anchor a tooth on towards the back of the mouth.
So I'm a little bit unfamiliar with these terms. What does it mean, a bridge? I mean, why do you explain bridging?
So a bridge would be, I wish I had a picture of it. I don't. Actually, I can show you, maybe I can show you this. So can you see this?
Yes, perfect.
Okay. So this is an example of an extraction that was poorly managed and they really roughed up not only the gum tissue, but the bone underneath. Now, this patient will ultimately end up with a bridge, traditional fixed bridge, which will attach the natural teeth on either side. It will connect them together. We're going to bypass the area of the crummy bone, and you're going to anchor onto the teeth on either side with what you would think of just a crown, right? A crown tooth. You're going to have two crowns connected together in the middle with like a dummy crown replacement to fill the gap.
So is the bridge in the back, obviously, because you can't see it? Is it behind the tooth, the bridge?
No, it's picture like a good analogy is like a coffee can on a fence post. The bridge is literally two crowns that go all the way around the tooth. So you have basically a peg of a tooth, and you're going to cover up that peg with a crown, and it's connected to another one with the same thing. So then you can fill in the gap.
So I'll share this. I'm a little bit reluctant to share it, but when I was 6, my sister was 8. We were horsing around, and I flipped her over my back, tooth first, into the wall.
Yeah.
And she lost her front tooth.
Got it.
And, it was very traumatic for her, very traumatic for me. And her teeth look great now. Let me just say that. But it took a long time to get it right.
Right.
She had quite an ordeal where it just looked wrong. Right.
And that's common. We see that a lot.
Yeah. So I'm just wondering if you could fill in maybe your experience in the journey that people like my sister have gone through in order to, from the time she was 8 years old, into a adult, really.
Yeah, and unfortunately, we do see that scenario, and it's hard when you have a younger patient because dental implants are really not an option for a patient until they're done growing. So that's roughly 18 to 21.
Oh,
We've seen some horrible scenarios where dental implants were placed on 14, 15, 16-year-olds. And then they come into our office, they're referred over by a general dentist who says, I don't like the way this looks. Can we do a tissue graft to cover up this weird looking tooth? Because the body keeps growing. The maxilla, the jawbone, will keep growing as he or she develops. It grows down and kind of around where the implant is. The implant is fused with the bone. The implant is a titanium fixture. It's medical grade titanium. I don't know if you can see that. It's what it looks like. It's threaded.
Yeah.
And then on the implant goes what we call an abutment, which is another titanium piece that threads into the implant. And then on the abutment, so like for your sister, then they put a crown. So it's a very, very super effective, very predictable way to fix or replace a missing tooth. You know, these are successful long-term, you know, over 97% successful long-term. But when placed in a young patient, everything kind of grows down around it because that implant is fused with the bone. It's not going to move from where you place it. So then now you end up with a tooth that is far too up towards their nose and it doesn't look right and they're unhappy. So there's only two ways to fix that, is to either prosthetically do some things with some pink porcelain on the crown to kind of match the gum tissue to get it to blend in, or we're taking those implants out and starting over from scratch. So like for your sister who had maybe a long road of crowns that don't look quite right, you know, on average, a typical crown or a bridge, it's good for roughly 10 to 12 years. If you go by the literature, they say crown and bridge work will last about a decade. You know, now I've seen crowns and bridges in patients that have been in there 40 years. So there are exceptions to that, but your sister's probably had a number of crowns over the years. And unfortunately, you know, it maybe at some point she'll have to go with the implant option because that tooth is just done. Like it can only take so much, you know, to a certain point.
Well, who's ever done whatever, it looks great now. You would have no idea that she's ever had
Awesome.
a tooth problem. But it took a long time for her to get to that point.
Yeah.
So gums, like what about receding gums? Like if I smile for you, you can, I don't know if you can see.
I can't really see on my screen, but
But do you know what I'm talking about? How the gum sort of pulls away from the tooth? And
I do.
my dentist says it's nothing to worry about. It's just a cosmetic issue.
Right. So there's really a few criteria that we look at and evaluate for recession, and that's a big thing that we deal with. We do a lot of tissue grafting in our office, and you know the things that we look for. One is, you know, cosmetic concern. Most patients they don't like the way it looks, and they come in, they say, "Fix this, cover up the root of my tooth. I don't like how it looks." Another reason would be sensitivity. You know, if you feel it with your fingernail or you hit it weird with your toothbrush, you get a little zing, you know, from mechanical stimulation or temperature, that would be another reason to do a tissue graft to cover it up. Third reason would be just functional stability. There's a certain type of tissue that we like to have right at the gum line that's keratinized tissue. It's a thicker, more rubbery, dense tissue. That's what keeps the tooth healthy as we age. So when you go to brush your teeth, the mechanical action of the toothbrush against keratinized tissue, there's a very good cleaning effect. If you lose all that rubbery, dense tissue and you get the real soft tissue on the inside of your cheek, we call that mucosa. If you have mucosa right up against the root of a tooth, when the bristles of the toothbrush hit that area, they can never get to the tooth, the surface of the root, to really clean it. Now that turns into a much bigger issue. We see what we call unzipping of the tissue, where you get a lot of recession in a short amount of time. You get cavities on the root surface, just much, much harder to treat. So for me, a good rule of thumb is if you have very little or no keratinized tissue, then we're recommending a tissue graft. If you still have a good band of it, and the other issues are not there, like you don't care how it looks, it's not sensitive, then I say keep it clean, use a soft toothbrush, no medium or hard, don't go crazy on it and sawing away at your gums, and you'll be fine.
You think
those
it's
are
a
the
matter of time because it is receding that it will eventually need some sort of intervention?
Not necessarily. So there are a couple of big risk factors for recession. The biggest one would be just your own iatrogenic, medium hard toothbrush over long periods of time. Another thing that really factors into it is your occlusion, how your teeth come together, and if you grind your teeth at night. So if you are a grinder and you're seeing more recession and you're stressed out because of your job, whatever it may be, but if you grind your teeth at night, that is a very high risk factor for recession. So
I've always been a grinder forever.
And a lot of people are. So what we do for those patients is we make them a night guard. It's a custom fitted, kind of looks like an athletic mouth guard, but instead of being that kind of rubbery, like dense material, it's hard. And so these night guards have a hard shell that's very protective to your teeth. So when you're grinding at night, the hard shell allows good, safe side-to-side movement, so you're not putting a lot of side loading on your teeth. Teeth are very good, same with implants, very, very good and resistant to vertical compressive forces. As soon as you start hitting teeth or an implant with a lot of lateral forces, you start seeing bone loss, you start seeing recession. It's inevitable. It will definitely happen.
But I've had recession for a while. I mean, and I've had grinding forever.
Right?
Does it interfere with sleep, these night guards?
What's that? Say that
Does
again.
it interfere with sleep, these night guards?
I've heard it both ways. Some patients say that the first couple weeks it takes some getting used to, but like anything, you do get used to it. Your body will accommodate, you will adjust, and yeah.
Does insurance pay for it, or do you have to come out of pocket on that?
It depends on the plan, but some insurances do, some do not.
And how much do they generally cost?
$700 to $800. Let's say
Wow.
800. Seven's probably average. You might be able to find one for $6.
And what about dental implants? How much do they cost? And does insurance not cover those either? And
no, surprisingly. So I think insurance companies, it's a numbers game for them, and they're not in the business to lose money. So I think the bean counters have really analyzed it. And in certain situations, I think some insurances, not all, but they are starting to cover implants because they know that that's a permanent, lifelong fix rather than doing a bridge, because that's one of the other options. A bridge, which may have to be replaced after 10 to 12 years. So the insurance kind of sees it as it's a one and done. The two are roughly equivalent in cost. A fixed traditional bridge on natural teeth versus a single implant to fill in a space are about equivalent in cost. One single implant, just the implant fixture, the gray part here that we place in the jawbone is around $2,300. The connection piece that goes on top of that's roughly another $1,200, and then you have a crown that's like $1,400 on average. Now in our office, we only do the gray part, the implant fixture. We do not do the crown. We will help the general dentist. We want to make their life as easy as we can, and that kind of helps create some job security for us if we make their life easy. But we will help pave the way for them to make this abutment. These abutments are custom made. They used to be, this is a model that shows a standard, what they called stock abutment. Standard stock abutment is like going to the store, buying a shirt off the rack, small, medium, large. you don't have a lot of room to really tailor this. Now what they do is they take a scan of a taller version of this. There's a little post that we put on the implant, taller, like twice as tall as this. They take an impression, scan that, and then they mill through the CAD technology, they mill out a custom abutment that fits precisely the patient's situation. The nice thing about that too is the custom abutment, this screw or this crown is held on with a screw. So rather than the day you go in to get your crown after your implant has been placed, it used to be they'd put the crown on with cement, and you're pushing this crown down onto the abutment, and all that extra cement goes below the gum line. And it's going below the gum line down into an area where we don't want it to get close to the implant, because then that creates issues down the road. So now we can hold these crowns on with a screw, much easier, safer, more predictable, a lot of perks to it. If there's ever an issue with this, I like to use the analogy, it's like Legos. You can literally deconstruct this. You can take apart the pieces and redo it if you had to. It's a huge advantage versus the old cemented crowns. They were kind of a nightmare to work with if you ever had an issue.
Do you have any social media presence? Like you have a Facebook page or a website that we can direct folks to?
No, we do through the office. I'll get you the link for that. You can maybe put it in the show notes. I don't have my own personal periodontal page. I've got a personal account, but I'll get you the one for the office.
And if you were a lay person with a tooth problem, obviously you'd start with your dentist. But how does one find a periodontist?
So, I mean, you can do a Google search to find, periodontists out there. Depending on the problem, most people already they're established with a general dentist. So if they break a tooth eating peanut brittle one night, first call they're going to make is to their general dentist, tells them what happens. A lot of times, if it's a broken tooth like that, the general dentist won't even have them come in. They just skip the middleman, so to speak, and have them come straight to us, because they know, they're not going to be able to treat them the way with what they need at the general dentist's office. So they just send them straight over to us.
So I've broken a tooth before, and he's been able to fix it. I'm not sure what that's called. I don't think he put a crown on it.
Yeah, it depends on how it fractures. There's different classifications, Ellis classifications for fractured teeth. But I mean, the ones that we see when they break, they're broken at the gum line. There's nothing left. Actually, I've got a picture I can show you. There's just nothing left to work with to save it. I don't know if you can see that.
Right in the middle.
Right in the middle. And that's kind of a common case that we will get, is a tooth broken off at the gum line. Those teeth typically have a long history, maybe much like your sister, a long history of dental work, trauma at some point years prior. They go through, do a root canal, and then over time, after you do have a root canal done, the tooth starts to dry out a little bit. It gets a little bit brittle. So you eventually are very susceptible to a fracture in the tooth. This is a case or a scenario where you've got a root canal treated tooth, a long history of a lot of work, a buildup, a crown, so a big filling, a crown. A lot of times they put a rigid post down into one of the roots on these teeth.
Mm-hmm.
And then all it takes, right place at the right time, you bite into something hard, it puts enough force on that tooth internally to then crack the root in a vertical fashion. And then I've seen a tooth go from having the fracture happen to this, where extreme bone loss, basically have a tooth floating in a black hole. I've seen in as little as 3 months. So it's, yeah, it can be pretty significant, but that's kind of, we see, I would say the more extreme side of the spectrum. You know, somebody who just chips their tooth a little bit, yes, the general dentist is going to be able to fix that.
So just to end, getting back to my sister, she loses her tooth. You know, I'm 6, but if I were 26, what do I do? Do I put it back in? What are you supposed to do when you have a traumatic loss of a tooth?
Right. So, I mean, there's a lot that factors into that. So there's no just like canned answer. Significant amount of the success of that depends on how long the tooth has been out of the mouth. So if you knock a tooth out or avulse the tooth, if the patient comes into us, we assess for any fractures to the alveolar plate, the buccal bone on either side. Sometimes that bone can break down and be fractured. And if you place the tooth back in, sometimes it's hard to get stability on it. You know, we'll splint it, we'll put the tooth in position and then create kind of a splint to hold it in place, almost like braces. But at the age of 26, if the tooth has been out of the mouth more
No,
than
she's 8, I'm 6. But if I were 26, what should I have done? Should I have taken the tooth and put it back in and then take her to the emergency room, or you know, how do you do it with it emergently?
Yes, if you're 26 years old and you get a tooth knocked out, best thing to do is stick it back in. You know, there will be some discomfort associated with it, but that's the best thing you can do.
And then go to the dentist or go to the emergency room. Where do you go from there?
If you go to the emergency room, they will have, you know, they're going to have an on-call staff oral surgeon or dentist that they will have come in and evaluate it. Chances are, though, they're not going to do a definitive fix in the ER. So it will take going to someone like myself. A lot of general dentists would be capable of doing that little splint, you know, putting the tooth in, splinting it. If you need sutures to kind of hold the tissue together, sometimes we do that. But really, that's something that a dentist or a specialist like myself, we would handle.
What about putting the tooth in milk? Is that something that is done?
It's better than water, but really the best thing is to put it back in the mouth. And if you don't feel comfortable putting it into the extraction socket, at least just hold it down in the cheek. You know, if you're 26 years old and you got the wherewithal to keep it in your cheek until you can get to the office and have them deal with it. Because you're talking about the pH. If the pH is not favorable, all the cells in what we call the periodontal ligament, and around each tooth, you have a little ligament and a blood vessel that goes with it. And that ligament is like a shock absorber on your car. And there are little cells that are very fragile. And if the pH is not nearly the same as what's in your mouth, those cells die very quickly. And then the chance of that tooth remaining vital after you reimplant it, next to none.
Okay, I want to plant a seed with you too. Maybe Christy, who helps manage DocTalk Live, can help facilitate this. But it would be kind of interesting if you could find a patient who's willing to get on camera with you and just sort of go through the various options they have in terms of the evaluative process. Like, hey, you know, this is what's going on. You know,
right.
These are your options. And if you could and Christy probably could show you some other DocTalk Lives where we've maybe have patients before we talk about things. But that would be, I think that might be informative, because then the patient would ask questions perhaps that are not that are more patient driven.
Yeah, that would be great. And I mean, there's so many different areas and treatment plans that you could get into with that. That is the nice thing about periodontics, is that our specialty overlaps with everything in dentistry. I mean, we see pediatric patients, we see orthodontic patients, endo patients. I mean, we cover the range of everything. So it makes the job fun for me because there's never a dull moment. Each case is unique and has its own challenges, and you got to work through it and figure out a good plan. You know,
Yeah, I think that would be interesting for people who like to check out this stuff on social media. Eric, I want to thank you for your time tonight.
You're welcome.
I appreciate it.
Absolutely. We'll talk again soon.
I look forward to it.
Take care. Thank you.
Thanks, Eric.
Bye-bye.